So on behalf of Dr. Sushma Bhatnagar, Madam, President of Indian Association of Palliative Care, I welcome everyone to this series 4 of our IAPC online lecture series, which is on palliative pharmacotherapy in palliative care. And Dr. Sushma is traveling, so since my group from Tata is presenting, so I am carrying on with this morning session. So welcome again, everyone. This is an activity now we've been doing in our 4th year. So it is right in our DNA to get up at 6:15 on a Monday morning and log in for this lecture. So thank you very much. It provides us so much of learning and interacting. So for today's session, it is on drugs used in nausea, vomiting, part 1. And to present the session is Dr. Anshita Sharma, who has completed her MBBS and is doing her MD palliative medicine in Tata Memorial Hospital. She's in her 2nd year. She is interested in palliative medicine in the emergency department and hence has done some work and presented a poster in the same topic. Her other interest is palliative care in patients with hematolymphoid malignancies. To moderate this session, we have Dr. Prarthna Jayaseelan, who you have met before. She has presented and she has moderated our session. So she has MBBS MD. She completed her MD palliative medicine from Tata Memorial Hospital in 2021. So she's working as senior resident with us now. She and Anshita both are certified eco-pediatric palliative care provider, having done the course for 1 to 2 years. And both Anshita and Prarthna are very steady and sincere in their work and very involved in departmental activities and great team members. And Dr. Prarthna, I consider her as a personal clock, because you know when she is in the OPD, that is the time that the OPD should start. She is never ever late, and if she is not there, that means unfortunately something has happened to her, and it had happened because she was not well. She is feeling a bit better today. So I gave over to Dr. Anshita to present her seminar, and to Dr. Prarthna, who will be moderating this session. Over to you both.
Thank you, ma'am. Good morning, everyone. My name is Dr. Anshita Sharma, and I'll be discussing part 1 of nausea vomiting.
Anshita, click on the screen and it will come.
Slide is not changing.
Do you want Archana to do it from her end? You did try that time and it did happen. Just try again. Otherwise, Archana will do it from her.
Sure, ma'am.
Ma'am, it is.
Yeah, great.
So I'll be covering the part 1 of nausea vomiting under the following headings. In the part of definition, etiology of nausea and vomiting in palliative care, pathophysiology, classification and receptor site and affinities of antiemetics, clinical presentation of nausea and vomiting. Again, stuck actually.
If you go on the screen, Anshita, if you go on the screen, move the cursor, you will see the arrow which will put it forward because you made it on key, right? You made it on keynote. And if you can't, I think it's better that Archana does the changing of the slides. Otherwise, we will be spending some minutes on it, which we need to carry on because it's a bit topic. Just see if it happens, or else Archana will take over.
It is not happening.
Okay, I'll pull up the screen. Not to worry. Yeah, is this fine?
Yeah, ma'am. Yeah.
Okay, just let me know when you want me to change slides.
Yeah, ma'am. Please change the slide.
Yeah. This one?
Ma'am, next one.
Yeah.
So, nausea and vomiting are common symptoms near the end of life that can cause substantial physical and psychological distress for patients and their families and significantly impact the quality of life. Approximately 60% of patients with advanced cancer report nausea and 30% report vomiting. The reported case by 70% of cancer patients in their last month of life complains of nausea and vomiting. 20 to 50% patients with other chronic illness like CKD and CHF can present nausea and vomiting. These symptoms are demeaning, reduce patients' quality of life, and may impact their compliance with their therapy. Most of the time, it can be managed in 90% of patients. And please change the slide. To define with nausea is an unpleasant sensation of the need to vomit associated with decrease in gastric tone and peristalsis and increase in the tone of duodenum, frequently expressing autonomic systems such as pallor, cold sweats, tachycardia, and diarrhea. Retching can be defined as an attempt to vomit without bringing anything up and characterized by spasmodic movement of diaphragm and abdominal musculature with the glottis closed, denoting the labored rhythmic respiratory activity that frequently precedes the emesis. Next slide. Vomiting is an observable neuromuscular reflex, forceful oral expulsion of gastric content through mouth. Vomiting involves forceful contraction of abdominal muscle, contraction of pylorus and antrum, a raised gastric cardiac activity, decrease in lower esophageal sphincter tone, and esophageal dilatation. Early satiety defined as the sensation of fullness after ingestion of small amount of liquid or solids. The next slide. So, common causes of nausea and vomiting in palliative care can be categorized under the following heading, including toxins and metabolic effects, disorders of viscera, and CNS related causes. So, in toxic and metabolic heading, we have drugs which causes nausea and vomiting, which include antibiotics, anti-seizure medication, chemotherapies, digitalis, and NSAIDs, opioids, SSRIs, and theophylline. And in case of organ failure, liver and renal failure can stimulate the vomiting center. The hypercalcemia, hyponatremia, and ketoacidosis can stimulate the vomiting center. Then the disorders of viscera like biliary pancreatic duct obstruction, gastric outlet obstruction, small bowel obstruction, hepatomegaly, severe constipation, gastroparesis, inflammation or mucosal irritation include chemotherapy-induced mucosal irritation, cholecystitis, gastritis, gastroenteritis, hepatitis, NSAIDs, pancreatitis, and radiation-induced mucosal irritation, tumors of GI tract, ascites. Then the CNS causes include the causes which lead to increased intracranial pressure like abscess, cranial irradiation, intracranial malignancy, hemorrhage, meningeal infiltration, drugs which stimulate the vestibular system. It could be drug effects or labyrinthitis. Anxiety can induce the anticipatory nausea and vomiting, and pain is also one factor which can induce the nausea and vomiting. So in the pathophysiology of nausea vomiting, we'll be covering emesis pathway, physiology of vomiting center, receptor and neurotransmitter involved in nausea and vomiting. Next slide. So emesis is mediated centrally by two separate centers, the chemoreceptor trigger zone in the area postrema in the floor of fourth ventricle and the vomiting center. Neural inputs from chemoreceptor trigger zone, vestibular system, higher cortical center, and thoracoabdominal organ is integrated in the vomiting center. Then vomiting center, it is located in the lateral reticular formation of the medulla and is the final common pathway. Brainstem nuclei is such as the parvicellular reticular formation, the Botzinger complex, and the nucleus tractus solitarius are collectively referred as the vomiting center. The main receptor present in the vomiting center is serotonin receptor, histamine receptor, neurokinin, and acetylcholine receptors. Then the area postrema, it is a circumventricular structure located at the caudal end of fourth ventricle, positioned outside the blood-brain barrier and so accessible to emetic substance which are born in either blood or in CSF. The receptor presents are NK1 receptor, dopamine 2 receptor, 5-HT3 receptor, and CB1 receptors. Next slide. Cerebral cortex, higher inputs from cerebral cortex like memory, fear, anxiety. Receptors presents are NK1 GABA receptor and 5-HT receptor. Then the vestibular nucleus, input from vestibular nucleus regarding the balance and the movement. In vestibular nucleus, the receptors are histamine and acetylcholine muscarinic type of receptors. In stomach and proximal bowel, local mediators from enterochromaffin cells stimulate the vagal and splanchnic efferent fiber within the bowel wall, signal to the brain stem, either directly to nuclei within the vomiting center, such as nucleus tractus solitarius, or indirectly via the area postrema, initiating the emetic reflex. So the primary receptors in GIT, 5-HT3 receptor, neurokinin 1 receptor, and CB1 receptor. And next slide. So in general, these are the etiologies which we can remember. Sorry, ma'am. No, ma'am, previous slide only. So, ma'am, these are the 5 areas where the integration happened for occurrence of nausea and vomiting. The stimulus could be from cerebral cortex or GIT or vestibular apparatus or chemoreceptor trigger zone. Now, when we say these components, these are stimulated by various sensations that can lead to elicitation of vomiting center. Finally, which is a central pattern generator for occurrence of nausea and vomiting. And these stimuli that leads to nausea vomiting would be, if it in the cerebral cortex, the sensory input could be in the form of pain, smell, sight, anxiety, memory, meningeal irritation, and raised intracranial pressure. In GIT, because of serotonin release from GI mucosa, the sensory input could be in the form of obstruction, stasis, inflammation in GIT. In chemoreceptor trigger zone, as there is no blood-brain barrier, so any metabolite or drug can stimulate it, and it can lead to elicitation of vomiting center and the vomiting. Vestibular apparatus, the sensory input in the form of motion, CNS lesion, opioids, aggravate the most of the nausea and can lead to vomiting. So these are the centers which are involved in the occurrence of vomiting. The management also depend upon the stimulus present and the action on the various receptors that are present on various sites, which include cerebral cortex, chemoreceptor trigger zone, vestibular apparatus, and GIT. And next slide, please. So now in this diagram, we can see that when the receptors are activated by various stimuli, they can lead to increased salivation. They can lead to abdominal muscle contraction, relaxation of lower esophageal sphincter with the diaphragmatic contraction, and retrograde contraction of the GIT that finally lead to vomiting. So this is how the pathophysiology of vomiting happen with patients who has stimulus from any of the places from where we just discussed. Next slide, please. Next slide. The previous one.
Anshita, there's no content here.
And should I try to share my screen?
Okay, if you want to.
Can you go on to the next one and see if it is there by mistake?
No, this one. This is the next slide, ma'am.
We have 2 slides in between these 2 slides. We have 2 slides next.
No, this
Anshita,
is.
go to the next slide. It's fine.
See, I have this, and then this, and then this.
There's no content visible on both the slides.
Maybe you can just present.
Okay. So receptor site and affinities of antiemetics. So on the basis of the action of antiemetics on various receptors, will decide the affinities of antiemetics. So like domperidone, it primarily has greater affinity for dopamine 2 receptors. Then the haloperidol primarily has greater affinity for dopamine 2 receptors, and along with that, it has affinity for 5-HT2 receptors as well. Then the metoclopramide, it has main activity on D2 receptor and 5-HT4 receptor, and to some extent on 5-HT3 receptors as well. Then metoclopramide, and then hyoscine butyl bromide, primarily its affinity for muscarinic receptor. Then chlorpromazine, its main site for action is D2 receptors, histamine receptor, and to some extent on muscarinic and 5-HT2 receptors. Next slide. Then olanzapine, it primarily act on D2 receptor and 5-HT2 and muscarinic receptors, and it also has some affinity for 5-HT3 and histamine receptors. Then promethazine, primary site of action is D2 receptor and muscarinic receptor and histamine receptor. Lorazepam, primary site of action is GABA receptor. Nabilone, site of action is CB1 receptor. Aprepitant has maximum affinity on NK1 receptor. And ondansetron and granisetron mainly act on 5-HT3 receptors. The next slide. I don't know why the half of the slide is visible. And if you'll just, I'll just check it.
Sometimes the keynote feature doesn't work on PowerPoint.
But I have a PPT in the form of I have a.
No, Apple, no, yours is Apple.
So you can explain what you mean on the slide, Anshita, because you have your presentation open in front of you. We can sort of go through that.
Yeah, ma'am, I can do that.
So this, I guess you are talking about your metoclopramide and domperidone.
And erythromycin. So
Yeah.
in this slide, we are checking the comparison of prokinetics drugs based on the receptor action. So the first one is the motilin agonist. The example of this particular class is erythromycin, which primarily act on motilin receptor. Then the D2 antagonist, the second one, and the example is domperidone and metoclopramide. And the third one is 5-HT4 agonist. The example is metoclopramide, act on 5-HT4 receptor. Ma'am, next slide, please. Yeah. So clinical presentation of nausea and vomiting. So we will be discussing this thing in under the heading of approach to a patient with nausea and vomiting. And chemotherapy induced nausea and vomiting, radiotherapy induced nausea and vomiting, and opioid induced nausea and vomiting. So in the history, risk factor and protective factors and etiology. Ma'am, please change the slide. So in history, the past antiemetic use affect previous history of nausea and vomiting. In risk factor, will ask about the history of motion sickness, pregnancy-related nausea, GI problems, age younger than 50, female, past history of nausea, vomiting associated with chemotherapy, and etiologies we discussed earlier in the form of mnemonic 10M, and other are CNS pathology, vestibular anxiety, GERD, peptic ulcer, cough, and previous history of nausea, vomiting. Always treat the reversible cause. This should be our primary aim. Next slide, please. So while taking the history or examining the patient, we'll have to go through certain points. So in the nausea, we have to ask the intensity of nausea under the scale of 0 to 10, then the duration and description, aggravating or activating factor through smell of food, eating, drinking, not eating, medication, movement, and time of day. Then the quality of life disturbance because of nausea and vomiting. Symptom associated with nausea, vomiting, such as fatigue, anxiety, depression, sweating, pain, constipation, and diarrhea. Number of episodes in 24 hours, and the alleviating factor, like what helps, what is helpful for distraction, lying down, medication, food, vomiting. Next slide, please. Then under the physical examination, we'll have to look for the vital sign, bowel sound, distension, tenderness, last bowel movement. Then we'll have to evaluate the under the certain blood investigation and radiological investigation to establish an etiology. Extent of evaluation depend on the goals of care. Goal to include comfort, functional restored, and check the hydration and nutrition. And focus should be on the patient and family as per the goals of care. Next slide, please. So for the mechanistic approach to management, we have 9 points which need to be remembered. So we have to identify the likely cause, the established pathway, the neurotransmitter which is involved in that pathway. Choose the most potent antagonist to that receptor identified. Choose a route of administration that ensures that drug reaches the site of action. Titrate the dose carefully. Give the antiemetic regularly. If symptom persists, review the likely cause, and additional treatment may be required for an overlooked cause, or alternative treatment may be suggested by different causes becoming apparent. And if combining antiemetics, then potential drug interaction need to be considered. Next slide, please. So chemotherapy induced nausea and vomiting. The patient will present in the acute phase when the nausea and vomiting occur within the 24 hours after any cancer intervention. In delayed type of nausea and vomiting, more than 24 hours after any cancer intervention. In breakthrough nausea vomiting, it happens within 5 days after getting nausea and vomiting after getting chemotherapy. In anticipatory nausea vomiting, it happens before any cancer intervention, and in refractory type, there's no response to any anti-nausea medications. The next slide, please. Then the risk factors for chemotherapy-induced nausea vomiting could be younger age, female sex, previous history of anti-cancer agent-induced nausea and vomiting, little or no previous alcohol use, prone to motion sickness, history of morning sickness during pregnancy, anxiety, high pre-treatment expectation of nausea. So next slide, please. So this is a diagram showing the effect of chemotherapeutic agent on various receptors. So in acute phase of nausea vomiting, the chemotherapeutic agent primarily act on the serotonin and to some extent on the substance P also. So to prevent the acute nausea vomiting, we'll have to block the 5-HT3 receptor to prevent the CINV. And in delayed type of nausea vomiting, we'll have to block the NK1 receptor. So we'll give NK1 receptor antagonist to prevent the chemo-induced nausea vomiting. Now, next slide. So hematogenic potential of anti-cancer agents and management. So according to the recent NCCN guidelines, there's a category of hematogenic potential of anti-cancer agent. So high hematic risk chemotherapeutic agent, the drugs which causes more than 90% frequency of emesis. So it includes certain drugs, mainly carboplatin, cisplatin, doxorubicin, epirubicin, ifosfamide. Next slide, please. Next slide. So to prevent the high hematic risk parental anti-cancer agents induced acute and delayed emesis, we have a guideline on first part. We are discussing the acute type of nausea vomiting, and we'll be giving either of the option given, either of the combination of medicine on day 1. So the option A could be combination of olanzapine 5 to 10 mg per oral once, NK1 receptor antagonist, either aprepitant, fosapretant, or rolapretant, and 5-HT3 receptor antagonist, including dolansetron, granisetron, or ondansetron, any of them, along with dexamethasone at a dose of 12 mg per orally IV once. Option B could be either only olanzapine 5 to 10 mg per orally, along with pelonosetron and dexamethasone. And option C could be combination of NK1 receptor antagonist along with 5-HT3 receptor antagonist and dexamethasone at a dose of 12 mg per orally IV once. And then for a delayed type of vomiting on day 2, 3, and 4, we'll give the combination of either olanzapine, aprepitant, and dexamethasone, or we'll give olanzapine in the form of 5 to 10 mg per orally on day 2, 3, 4. And we can also give the combination of aprepitant 80 mg per orally on day 2, 3, and dexamethasone on 8 mg per orally on day 2, 3, and 4. And next slide, please. So moderate to high hematic risk, more than 30% of frequencies of emesis in these type of agents. So in this, we have etoposide, crizotinib, lomustine, and olaparib. Next slide. So for moderate hematic risk anti-cancer agent on day 1, we will give combination of 5-HT3 receptors and dexamethasone in the dose of 12 mg per orally once, or option B could be olanzapine and dexamethasone, and option C could be a combination of NK1 receptor antagonist along with 5-HT3 receptor antagonist and dexamethasone. Then on day 2 and 3, option A, we'll give combination of dexamethasone 5-HT3 receptor antagonist, and we can give olanzapine in the dose of 5 to 10 milligram on day 2 and 3, and we can give a combination of aprepitant along with we can use dexamethasone, or if we don't want to use it, then we'll not use, we'll check the intensity of nausea and vomiting, and then accordingly we add the steroid in this part. Next slide, please. Next slide, please. Yeah. So low emetic risk in this type of anti-cancer agent, 10 to 30% frequency of emesis, and the drug involved in this category is cytarabine, docetaxel, doxorubicin, etoposide, 5-FU, mitomycin, pemetrexed. And in minimal emetic risk, when less than 10% frequency of emesis, the drug induced is bortezomib, cetuximab, cytarabine in the lower dose, 100 milligram per meter square, then nivolumab, rituximab, and hyaluronidase. Next slide, please. So for low emetic risk anti-cancer agent, we can use either dexamethasone at 8 to 12 milligram dose, or metoclopramide at 10 to 20 milligram dose, or prochlorpromazine 10 mg per oral IV dose, or one of the 5-HT3 receptor antagonist, either dolasetron, granisetron, or ondansetron. And for minimal emetic risk anti-cancer agent, we do not use any prophylaxis. The next slide. For breakthrough treatment for anti-cancer therapy induced nausea, vomiting, the general principle of breakthrough treatment is to add one agent from a different drug class to the current regimen, either atypical antipsychotic, olanzapine 5 to 10 milligram per oral daily, then the benzodiazepine, lorazepam 0.5 to 1 mg every 6 hourly, cannabinoid like dronabinol 5 to 10 milligram, or other drugs included like haloperidol, metoclopramide, scopolamine, phenothiazine, and 5-HT3 receptor antagonists like dolasetron, granisetron, ondansetron, and corticosteroid. Then we'll check for the effect of these drugs. If nausea and vomiting controlled, then we'll continue the same dosage. And if nausea and vomiting are not controlled, then we'll reevaluate and consider dose adjustment, and or sequentially add one agent from a different drug class. The next slide. So in this slide, which is not visible properly, so I'll read it. Emetic risk in adult by site of radiation therapy. So we'll be discussing radiation-induced nausea, vomiting. So on the basis of risk level and the site of radiation received, so high risk level, more than 90% emesis occur if the site of irradiation is total body. Moderate rate 30 to 90% if the site of radiation is upper abdominal, craniospinal. Then low risk 10 to 30% brain, head, neck, thorax, and pelvis irradiation. Minimal risk when less than 10% when the site of radiation is extremities and breast. Next slide, please. So if the site of radiation is upper abdomen or localized site, then we'll start the pre-treatment for each day of RT treatment. Granisetron 2 mg per oral daily, or ondansetron 8 mg per oral BD, plus minus dexamethasone 4 mg per oral daily dose. And the similar regimen in total body radiation also will start the pre-treatment for each day of RT treatment. Granisetron, ondansetron, plus minus dexamethasone. And if we are giving chemotherapy along with the radiotherapy, then we have already covered the treatment of chemotherapy-induced nausea, vomiting. So we'll follow that regimen. Ma'am, next slide, please. So opioid-induced nausea and vomiting. Patients who are being initially started on opioid may experience nausea or vomiting. Generally, tolerance tends to occur within days to weeks. Pathophysiology of opioid-induced nausea vomiting include enhanced vestibular sensitivity, direct effect on chemoreceptor trigger zone, delayed gastric emptying. So opioid will act by multiple mechanism at the central and GIT level. So low dose of opioid activate mu-opioid receptor in chemoreceptor trigger zone, thereby stimulating the vomiting. Higher dose of opioids suppress the vomiting by acting at the receptor site deeper in medulla. Endogenous opioid involved in mechanism of opioid-induced nausea vomiting by stimulating mu-opioid receptor and delta opioid receptor in chemoreceptor trigger zone of vomiting center. Then next slide. Inter-individual variation in nausea and vomiting among cancer patients receiving opioids may be related to polymorphism within the gene encoding proteins involved in the various processes like transport of opioid across membrane at blood-brain barrier, opioid receptor binding, and downstream signaling of opioid effect. The treatment, we can consider opioid antagonist as the primary treatment by either continuous naloxone infusion, naltrexone, nalmefene. Methyl naltrexone was shown to markedly reduce the nausea associated with parenteral morphine administration and also appeared to produce a decrease in vomiting in patients who received methyl naltrexone for reversal of opioid-induced urinary effect. D2 receptor antagonists may be used in OINV, although their prophylactic dose is not useful. Next slide. Antipsychotics like olanzapine decreased morphine-induced nausea and vomiting in a dose-dependent manner with a dose of 0.03 milligram per kg. So targeting specific areas or receptor subtype that opioids may directly or indirectly stimulate may lead to improved patient outcome for patients with opioid-induced nausea vomiting who require opioid for medically necessary treatment. Ma'am, next slide. Then the non-pharmacological measure to prevent nausea and vomiting will we'll discuss it under certain heading like on diet. So we'll have a nutritionist prescribed diet chart, frequent small meals, limit the dietary fat intake, presentation of food should be good, favorite food should be served to the patient, give food when the patient wants it. So, and medication will limit the number of pills, prefer to give the pills after meals when possible, have to take care of proper mouth care. Environmental factor like odors and lighting should be avoided. Positioning is really helpful. We'll have to teach certain relaxation technique and distraction technique to the patient. Ma'am, next slide. So in the last, I'll be discussing a case scenario. It is a 44-year-old female, stage 4 non-small cell lung carcinoma, severe nausea and vomiting, requiring hospital admission after first chemotherapy with carboplatin and Taxol, pre-treated with dexamethasone and ondansetron, oral ondansetron after chemotherapy, but could not keep it down. She did not drink or smoke, had motion sickness since childhood, had hyperemesis gravidarum with each of her 3 pregnancies. When she completed her family 10 years earlier, felt great relief that she would never have to go through that experience again. At admission, she was tearful and anxious, reported anticipatory nausea before each oncologist visit. Her mother-in-law, who was helping with her in her children's, was annoyed with her and believed that she was over-dramatizing her symptoms, said that her friends had undergone similar chemotherapy but was still be able to run their households. All the risk factors for severe nausea and vomiting, in this case, including female gender, age less than 50 years, motion sickness, hyperemesis gravidarum, low alcohol intake, high hematogenic drug that require high level prophylaxis for both acute and delayed chemotherapy induced nausea and vomiting. And next slide. Since acute vomiting was not prevented, developed delayed and anticipatory nausea vomiting. So quality of life may be improved by counseling, adjuvant acupuncture, cognition, CBT, and a more aggressive preventive pharmacotherapy using treatment guidelines. Counseling or of her family can be help them to understand why she is unable to tolerate chemotherapy and to plan for the support she needs. Cognitive therapy can help desensitize and provide strategies for her to better tolerate her treatment. For the anticipatory nausea vomiting to stop, however, she will have to experience treatment unaccompanied by nausea and vomiting, that is, uncouple the stimulus from the response. Since she is higher risk for CINV, before her first treatment, she needs prophylactic dexamethasone, aprepitant, and 5-HT3 receptor antagonist before and after chemotherapy. Benzodiazepine like lorazepam can be added for anxiety. Because she is unable to tolerate oral medication after chemotherapy, she might benefit from single dose of parental long-acting 5-HT3 receptor antagonists such as felinocetrone before her chemotherapy. Thank you.
Thank you very much, Dr. Anshita. Over to you, Prarthna.
Hi, so do we have any questions? Anshita covered a lot of things in her slide, important points, but unfortunately we couldn't see that. I had the slideshow open with me, so I think we will forward the presentation in which some of the blank slides were in there. So we'll avoid those. We'll send you all the proper presentation. And I think that slide where the 10 M's was there, where it is missing. So can you just read that out, Anshita? This we should keep in mind while assessing for the etiology. It's an easy mnemonic to rule out the causes for nausea vomiting.
So for the etiology of nausea and vomiting, in general, there are etiology which can remember by the mnemonic 10M. In this 10M, the M1 stand for metastasis. For example, the metastasis to brain, which leads to raised intracranial tension, which further lead to nausea, vomiting. M2 is a meningeal irritation, like which occur in the case of leptomeningeal diseases. Then M3 is medications, which include opioid, chemotherapy, and NSAIDs. M4 is movement related, like vestibular stimulation because of certain drugs or vestibular diseases, labyrinthitis. Then mentation, M5, like anxiety. And in mechanical, M6 is mechanical stimulus in the form of example, constipation, tumor, stricture, or peritoneal deposits. Then M7 is a metabolic like hypercalcemia, hyponatremia, liver and renal failure. Then M8 is a motility related, like in case of opioids and paralytic ileus. M9 is mucosal, and mucosal irritation either with some certain drugs like NSAIDs or chemotherapeutic agent or just GERD. And M10 is microbes. So any kind of fungal or bacterial or viral infection can lead to irritation of mucosa and can lead to nausea and vomiting. So these are the 10M which we need to remember under the etiology of nausea and vomiting. Thank you.
Thank you. Okay, we have a question from Meenakshi. So she is asking us, Anshita, can you elucidate where we should prefer metoclopramide over domperidone in our day-to-day practice?
So just now we have discussed like in the under the heading of etiology as well. Then if we find the pathology related to the motility of GI tract, we'll prefer the metoclopramide over domperidone, and we'll prefer the domperidone for the nausea component primarily over metoclopramide. So yeah, and metoclopramide, it acts on the 2 and 5H24 receptors, so it is a potent prokinetic. So we'll prefer metoclopramide over domperidone.
And plus, domperidone will be more peripheral. Metoclopramide will act on the CNS D2 receptors, Dr. Meenakshi. So, I think there are lots of thank yous to Dr. Anshita for a very comprehensive and excellent presentation. And I think that you worked very hard on this. There are just two things I think we should need to add. One is when you send on the presentation, please do check the references and put in them, because you've taken the guidelines for them. And recently, a lot of the anti-emesis guidelines have been updated, both NCCN as well as ASCO, because the previous one was 2016-17, but ASCO and NCCN is 2020 and 2020 onwards. The second thing is, there are two tools which are there, prediction tools for emesis, both for especially in chemotherapy-induced nausea, vomiting. One is the mask anti-emesis tool, which is called MAT, and the other one is a risk for emesis. So that is one of the other organizations. So there are these tools, and if you can please. There is a recent article on radiotherapy-induced nausea, vomiting. So if that mechanism, the drugs and the guidelines are good, the steps that we have said cover that. But if we can just add one slide on the mechanism of that.
Okay.
And there's a lot of literature on mechanism in chemotherapy-induced nausea, vomiting. So interested readers can look through that. And the 10 M's is one mnemonic, and the other one is vomiting for reasons. And the other way we can classify the causes as, and anyway, Anshita has already gone through that. It's like above the neck, below the neck, and systemic. So these are just some pointers to the experienced palliative care physicians and nurses will already know that, but these are the trainees, MD trainees who have recently joined may find it useful. So if there are no questions, I thank on behalf of Dr. Sushma Madam and IAPC to all of you for joining. Thank you for an excellent and comprehensive and really exhaustive presentation, Dr. Anshita. The thing to know is keynotes cannot be accessed by everybody, so we need to have a backup in PowerPoint, and even if you have that, the graphics do not translate well. So this is not just for Anshita, for everybody who uses Keynote. Please be mindful of that. And Dr. Prarthna, thank you for helping Anshita through the preparation and for moderating the session today. Thank you very much. Have a great morning, everybody, and have a great week ahead. Thank you. Thank you, Archana and Nisha and the IAPC team.